Hi, everyone. My name is Thuba Alwani. I'm one of the PGY2 residents in the internal medicine program.
I'm Jason Matos. I'm one of the non-invasive cardiologists at BI and Bloomgard Firm Chief.
So welcome to our first session on EKG Basics. Just a disclaimer, this session is going to be a little bit longer than our usual sessions, but we hope that it provides you with a good framework going forward. The goals of this session are firstly to identify the basic parts of an EKG and develop an approach to reading EKGs. We're going to identify rate and rhythm. We'll appreciate normal P wave morphologies and right atrial and left atrial abnormalities. We'll also identify abnormal intervals, including long QT and a prolonged PR interval. And then we'll appreciate some changes in the QRF complex, including abnormal access, bundle branch blocks, LVH, and Q waves. And then finally, we'll identify some basic ischemic changes. So this is just an outline of everything that we're going to cover today and the approach that we're going to use when we look at EKGs. Starting off with just some basics, I want to remind us that the heart is a three-dimensional structure, but we can utilize our leads and place them strategically in order to evaluate the heart in these three dimensions. And remember that anytime you have a positive depolarization that is traveling towards the direction of a lead, this will show up as a positive deflection on the EKG and vice versa. Some other basics that are helpful to know are the measurements on an EKG. So in our horizontal plane, we have time, with each small box being 40 milliseconds, and there's 5 small boxes and 1 large box, which comes out to 200 milliseconds. And then in our vertical plane, we have amplitude, with each small box being 1 millimeter and a large box being a total of 5 millimeters. And then this is just the basic parts of our EKG. So we have our P wave, our QRS complex, and our T wave, and then our most important intervals, our PR interval, as well as our QT interval. And briefly, just to go into ventricular depolarization, it's helpful to sort of understand why the QRS complex looks the way that it does. So the first part of the QRS complex is made up of the Q wave, which is depolarization of the upper septal area. Then we have the R wave, which is the main portion of the left ventricle. Then the S wave, which is the upper posterior portion. So now that we've gone through some basics, let's talk a little bit about rate and rhythm. So starting off with rate, there's different ways that we can measure our rate. The first way is the box method. And here you're going to measure the number of large boxes that are in between your RR interval. If there's one large box, this is 300 beats per minute, two is 150, and then 175, 60, so on and so forth. This is a really good method if your RR intervals are consistent. The other method you can use is utilizing the rhythm strip, which is a total of 10 seconds. So if you count the number of QRS complexes and multiply that by 6, that also gives you the rate. This is helpful if your rhythm is irregular and there isn't a consistent RR interval.
Add one thing to this too. Typically I use the counting method when the heart rate's irregular, yes, and also slower. When there's a lot of QRSs, it's challenging to count that many and multiply by 6. So when the rates are slower, I usually count the QRSs and multiply by 6, versus when the ventricular rate is faster, I usually use the box method. And again, I focus on ventricular rate because by counting QRSs or measuring distance between QRSs, we're determining the ventricular rate, not necessarily the atrial rate.
Exactly. So this sort of brings us into rhythm. And when we're looking at rhythm, it's important to distinguish what the atrial rhythm is versus what the ventricular rhythm is. So here I have some examples of different atrial rhythms. The first one is a flutter, which is a regularly irregular tachycardia, and then we have AFib, which is irregularly irregular. We're going to go through AFib and flutter in more detail, but I just wanted to present a brief overview for you guys. Other things that we can see are sinus pauses. So over here, we have a period of no electrical activity, and then we have resumption of our normal PQRST, which is consistent with a sinus pause. Other atrial rhythms that you can see, sometimes you have a premature atrial contraction, which is exactly what it sounds like. Basically, there's a P wave that comes a little bit early, and after this, you can have a compensatory pause. In addition to sort of atrial rhythms that we can see, there's also ventricular rhythms we can see. So commonly, you guys will see PVCs, a premature ventricular contraction, which is also exactly what it sounds like. It's when the ventricles depolarize without the normal synchronized signal from the atria. And then we have other rhythms such as VTAC, which is sort of consistent ventricular depolarization, and then more disorganized ventricular activity in the form of VFib. Jason, any other tips for people when they're approaching like basic rhythms?
Well, I think it's just how you laid out in these previous two slides. I think I like to teach it and think about it when I'm reviewing cases myself is what's going on in the atria and what's going on in the ventricles. And we try to consider patients having like an isolated rhythm, like it's atrial fibrillation. Well, that's what the atria are doing, and then it's figuring out in turn what the ventricles are doing. There are plenty of wacky cases we've seen in the CCU and otherwise where a patient could be in AF and VTAC. So I think it's just breaking that down, and we'll do more and more of that a little bit in this session and more in future sessions as well to get some practice.
Perfect. So we've covered now rate and rhythm. Next, we're going to move on to our P waves and our PR interval. P waves are positive in leads 1, 2, V4, and V6. They're negative in AVR, and P waves represent atrial depolarization that travels from the right side to the left side. However, when we're evaluating P waves, it's most helpful to look at leads 2 and V1. So in lead
Can
2,
you go back to one slide? Sorry, too, but
sorry.
just to emphasize that this is correct for sinus P waves, right? So
Mhm,
when we're depolarizing, just as that figure shows in the right, from when you're
mhm,
coming from the SA node, you're depolarizing toward the AV node, toward the LV apex from SA node to AV node, and that's why those leads are well aligned with that vector, and that's why they're positive in sinus rhythm.
mhm. Exactly. When we're looking at atrial abnormalities, specifically impaired conduction, it's helpful to look at leads 2 and V1. So if you have a very tall P wave in lead 2 that's greater than 2.5 millimeters, that's consistent with impaired right atrial conduction. You can also see a prominent positive deflection in V1. If you have a left atrial issue, you're going to see this notched P wave with the total width being greater than 120 milliseconds and the distance between being at least 40. You can also see a biphasic P wave in V1 with this predominant negative component. Jason, do you sort of want to speak to why we're calling this enlargement slash impaired conduction?
You'll hear it called enlargement all the time. The reason why often here we don't do that is there's been some studies, a lot of which were done out of former faculty members here, that looked at patients that had these ECG abnormalities and then looked at their echoes, and they don't necessarily have enlarged chambers. Some of them do, but some of them don't. But a better marker of this ECG abnormality is having delayed conduction in the chambers. When you actually put catheters in these chambers and measure the speed of conduction or the efficiency of conduction, and that is impaired when patients have these ECG abnormalities. So it may reflect that the chamber is enlarged, or the chamber may be enlarged concurrently, but it's not, having this ECG abnormality is not predictive enough for chamber enlargement to call it atrial enlargement. It's more left atrial abnormality or right atrial abnormality or conduction abnormality.
Mhm. Yeah, so for our purposes, we're sort of going to call it more impaired conduction than enlargement. Moving on to our PR interval. So a normal PR interval is between 120 milliseconds to 200 milliseconds. Anything less than that is short, and anything greater than that is long. A key tip to measuring your PR interval is to actually find a place where the P wave starts right on one of your large box markers. This way you can really quickly identify if your PR interval is prolonged because it'll be greater than one large box.
Yeah, that's great. I think that's always a great idea. You can see there that PR interval, as you go back, is
Mhm.
well over not just 200 milliseconds, but it's half of the next big box too. So this is a PR interval that's over 300 milliseconds.
Mhm. So next, we're going to dive into the QRS complex and axis, as well as Q waves. There's a lot of things to look at with our QRS complex. The axis, we're going to look at amplitude, width, and Q waves. So starting off with our axis. So when we're looking at electrical axis, our goal is to figure out where the net vector of the depolarization of the heart is pointing towards. And based on where this vector is pointing towards, that can tell us if there's certain pathology. So a normal QRS axis is between -30 to 90. Between +90 to 180 is a right axis deviation. -30 to -90 is a left axis deviation. And then within this range, we have an extreme axis deviation. So we can utilize the depolarizations in certain leads to determine where we are located within this circle. So starting off with a left axis deviation. In a left axis deviation, your QRF complex is mostly positive in lead 1, so we're on this side of the circle. We're negative in lead 2, which puts us over here, so we're moving away from lead 2. And then AVF is also negative. This results in an overlapping area between -30 and -90, consistent with a left axis deviation. Now, technically, you don't really need to use AVF. You can figure this out by lead 1 and lead 2, but we'll get into a little bit later sort of when AVF can be helpful. But it's included here also for completeness sake if you prefer AVF. In a right axis deviation, you have the opposite. So here you're actually negative in lead 1, so you're moving away from lead 1. That puts us over here. Positive in lead 2, so moving towards that, which puts us here, and then also positive in AVF, which results in an overlapping region right about here, consistent with a right axis deviation. And then we have our extreme axis deviation. So in an extreme axis deviation, we're negative in leads 1, 2, and AVF, which puts us with an overlapping region of -90 to -180, consistent with an extreme axis. So here, AVF can be somewhat helpful. Jason, I don't know if you want to speak to why AVF might be helpful here.
Yeah, I'll be honest. I use lead 1 and lead 2 predominantly. I guess the only time I would consider using AVF is when lead, like this situation, you can have a situation where lead 1 and lead 2 are both negative and AVF is positive, and
Mhm,
that would put you in that little yellow slice on the right,
mhm,
which I guess you could call that extreme right axis deviation, but not yet extreme axis deviation.
mhm,
So it'd be far right versus totally extreme. I guess that would be where you could incorporate AVF as opposed to just lead 1 and lead 2, which is what I typically use.
mhm, exactly. So for the purposes, usually it's okay to sort of use lead 1 and lead 2 when you're usually looking at access, but AVF can be helpful in certain situations. So let's look at an example. Take a moment to pause this video and try to figure out what you think the access is yourself. If you look here, you'll see that we're negative in leads 1, 2, and AVF. So upon first glance, you might think that this is an extreme axis, which is a good thought. But if you look a little bit closely, first of all, there isn't a lot of other pathology in this EKG. If there's an extreme axis, you would expect to see other things going on that would support why we have an extreme axis. So that's one point to make. The other thing to note is that your P waves are like inverted in 1 and 2. So this could actually be more consistent with a limb lead reversal. The other thing that you can think about is dextrocardia. However, if you did have dextrocardia, you would actually expect to see poor R wave progression. And here we have good R wave progression. So all that taken together, this is more likely to represent limb lead reversal. So just to remind yourselves that if you suspect an extreme axis, double check your P waves, are they inverted? And then look at your R wave progression to see if there's any evidence of dextrocardia. If you don't see all of this, then it's probably a limb lead reversal. Jason, any other tips for quickly spotting limb lead reversal?
Uh, no, I think the best is look at AVR as well. Um,
Mhm,
there are very little, very few cases where AVR should be positive. It's
mhm,
basically the complete negative. It's the reverse axis of the heart typically, and you're not often going to see dextrocardia. So for in your guys' cases, unless old ECGs have shown a positive QRS and AVR, it's traditionally limb lead reversal until proven otherwise.
Mhm. And we did see a positive ABR in this example. Okay, so now that we've talked about access, we're going to get into the amplitude of the QRS complex. We're not going to get too much into detail, but I just want to show you guys one example of an increased amplitude of your QRS complex, and that's LVH. And LVH has many criteria, but for today, I'm just going to talk about the Cornell criteria, which is the most sensitive. So here you're adding the S wave in B3 with the R wave in ABL. And if it's greater than 28 in men and 20 in women, that's consistent with LVH. We'll have another session on LVH and RVH later on. Other things to look at are the width of the QRS complex. So a wide QRS is greater than 120 milliseconds or 3 small boxes. This can be caused by a right bundle branch block or a left bundle branch block. So starting off with a right bundle branch block, here is our typical pattern. We have a slurred S wave in leads 1 and then in V6. And we also have this typical RSR prime pattern in V1, which is classically known as our rabbit ears or bunny ears. Note that you don't always see this typical bunny ear pattern in a right bundle branch block. And you can also expect to see some discordant changes in addition. A left bundle branch block also has a wide QRS. And then we have these broad monomorphic R waves in 1 and V6. And then we have our broad monomorphic S wave in V1. You can also expect to see discordant changes here.
I'll just add a couple things to that. One is with separate sessions on bundle branch blocks, we'll go into a little bit more. I mean, two of the diagrams here do demonstrate it, why the QRS complexes look exactly the way they do in right bundle and left bundle branch block. Also, two more things. Not every one of these perfectly fits right bundle or left bundle branch block. And if there is a sinus rhythm with intact AV conduction and a wide QRS that does not look like one of these two, we can call this IVCD, or which stands for interventricular conduction delay. You may see that at times. And the third thing is when we get to ventricular arrhythmias in another session, and I always tell house staff and fellows, the most important thing you can do to get good at recognizing ventricular tachycardia is to get good at recognizing normal bundle branch block patterns, because the criteria for VT, or ventricular tachycardia, are typically wide QRSs that don't look like normal bundle branch block patterns. So if you know what normal right and left bundle branch block patterns are, that's great for recognizing them, but it's also great for recognizing when it doesn't look like that and when it could more likely be something like ventricular tachycardia when there is AV dissociation as well.
Exactly, that's a really great point. Okay. So next, we're going to evaluate our Q waves. So Q waves, you can see benign Q waves, and then there's also pathologic Q waves. So pathologic Q waves indicate infarcted myocardium. They are usually wider and deeper than benign Q waves. So they're at least 40 milliseconds and at least 2 millimeters deep. Benign Q waves you can see in leads 1 in ABL. You can also see them in V1 and in isolated and lead 3. So just to go through like an example here. So in both of these EKGs, we're seeing Q waves, but if you compare the Q waves on the right side, you can note that they're actually a bit wider as well as deeper, indicating pathologic Q waves. Jason, any other tips when we're looking at Q waves?
No, I like how you had the septal Q waves there, and then you had shown earlier a diagram of like why a Q wave, like a normal Q wave exists. It's just that small depolarization of the septum when we're starting.
Exactly.
But no, I think that's helpful. And you know, this is a bit off topic. Typically, Q waves indicate infarction. There are other rare cases, such as actually in patients with really thick myocardium, hypertrophic cardiomyopathy, when there's like unopposed anteroseptal thickness, you can often get inferior like reciprocal inferior Q waves, but that's a bit more of a niche situation.
Also good to know. Okay, great. So we've covered our QRS complex access Q waves. Next, we're going to get into ST segment and T waves. So There's a lot to talk about with our ST segment, but for the purposes of this session, what I want you guys to identify is the ST segment represents this transition point between the QRS and the T wave. The G point specifically represents that transition, and your G point can either be sharp or diffuse. And then your ST segment itself can either be normal, it can be elevated, or it can be depressed. And anytime you're comparing the ST segment, you should compare it to the TP segment, which is your electrically neutral part of your EKG. And then when you have these ST depressions or elevations, they can either be flat, like they are over here, or they can have some concavity to them. And these patterns can represent different pathology, which we won't get into today. Jason, any other like quick tips for like basic ST changes?
Uh, no, all these are really good patterns to recognize, and I think you're right. I think it's best to go into these more detail in a dedicated session. I think there's a lot of ambiguity about this J point,
Hmm.
um, but typically it's normally sharp.
Hmm.
And when there is more of a diffuse J point, that traditionally indicates more concerning pathology.
Hmm. And then just a brief thing on T waves. T waves are normally inverted in AVR and V1. They can also occasionally be inverted in 3 and V2. If you have T wave inversions in other leads, this is pathologic. And T waves are also normally asymmetrical, kind of like what's shown here. So if you're seeing symmetrical T wave changes, that's also likely to indicate some type of pathology. Some common like T waves things that we see are peaked T waves. This can be seen in hyperkalemia. And we can also see hyperacute T waves in ischemia as well. And we'll go through all of that in our later sessions. And lastly, we're going to talk about the QT interval. So for our QT interval, we're starting to measure from the start of the QRS to the end of your T wave. Greater than 500 milliseconds is consistent with a long QT interval. And this can predispose you to bradycardias and other arrhythmias. So it's important to identify. Jason, how often can we like trust the QT that we get in our recorded EKGs?
For regular rhythms, it's pretty good.
Hmm.
It's always good to measure yourself. And again, the best way to do it is to start and find, just like we did with P interval, start when the Q waves are starting in a big box. And that helps you generally get the QT interval. We'll go over this in future sessions, but you can correct the QT interval for heart rate.
Hmm.
And then another way to assess QT intervals is normal QT intervals are typically less than half of the RR interval. And so
Hmm.
you can either eyeball that or measure that with calipers yourself. And like again, what long QT puts you at risk for are that long QT interval you see on the right. There's a lot more opportunity, like you guys learned from med school, for early after depolarizations that can lead to R on T phenomenon and unfortunately torsade.
Hmm. Perfect. So now that we've sort of gone through our approach to an EKG, let's practice utilizing our approach on a real example. Take a moment to pause this video and go through the EKG yourself. So starting off, we're going to look at our rate. So here I counted the number of QRS complexes and multiplied it to get 72 beats per minute. If we look at our rhythm, it's kind of interesting. So if you see that our RR intervals here are actually not consistent with each other. So there's some irregularity, but it's still sinus. We have P's before every QRS. Our P waves are of normal morphology. We don't see any evidence of, impaired conduction from our P waves. You can also see that our PR intervals are consistent. They're less than 200 of normal length. And then our axis is normal, so we're upright in lead 1 as well as 2 and AVF, so there's no axis deviation here. Our QRS complex is narrow, as you can see, less than 120 milliseconds of normal amplitude. We're not meeting any LVH criteria. We don't see any Q waves, and then there's no ST changes. And then our QT is also less than 500. So this EKG is more likely to represent sinus arrhythmia. So you can see some physiologic changes in your heart rate with respiration, specifically with inspiration, your heart rate can get faster. That's probably what we're seeing here compared to here where our intervals are a little bit longer. Jason, anything else you'd like to add when we're looking at this EKG?
No, I think it's absolutely right, but you'll see a lot of ECGs that look like this.
Mhm.
And not that it makes a massive clinical difference, but sometimes this will be read as like sinus rhythm with premature atrial contractions.
Mhm.
Um, the reason that's probably not the case here is that the P wave morphology looks very similar, and you'll see the sinus arrhythmia often in younger patients with more heightened vagal tone. Um, but otherwise, yeah, I agree, spot on.
Perfect. So this concludes this concludes this session. We hope that you learned a little bit about how to approach an EKG. And please join us for our next session on LVH, RVH, and strain.